All right, just to check, Claudine, if you can you see the slide?
I see a black screen. Yep.
And it says alternative to opioids?
Yep.
Perfect.
Looks good.
All right. Thank you.
Hi, Alexis.
Hi, how are you?
Good. Good luck.
Hey.
I'm going to give it 2 more minutes. Mm-hmm. One minute, guys, and then we'll get started. All right, well, just to get started, thanks everybody for being on the call today. I'm going to turn this over to Alexis in a couple minutes, but I wanted to give some opening remarks and some background. It was a couple years ago when I approached Alexis, who you guys will know very well shortly, stating that we have this big problem with opioids and wanted to brainstorm with her to come up with a strategy to be better at acute pain management in the emergency department, and to do that without the use of opioids. Alexis agreed to take a 1-year acute pain fellowship that was done out of New York Medical College in conjunction with several other hospitals in the New Jersey, New York area, and came back with tremendous knowledge base and has put together a program that blows me away. And I couldn't be more excited that once we announced this program publicly, there has been really international support. We just got off a conference call with The Guardian, which is I believe a magazine out of the UK, who is interested in this program. We've talked to countless state and national politicians, legislators, senators, and representatives. So this has been absolutely an overwhelming success for us. We just got called by NBC Nightly News that they want to do a segment on this program. And what I think is important here is not the success that Alexis is, that we're all hearing from this, is that this is an opportunity for emergency physicians who are on the front line to really change the discussion, to really make it on how we can manage acute pain efficiently, effectively, by using alternative to opioids first. So I don't want to take out any more time, and I really want to turn it over to Alexis. We have to change seats to get started, so but I'm going to hand the controls over to her, and we have time for questions and answers at the end. So Alexis, please.
Hi, everyone. Thank you for joining us. So I am here today to talk to you about alternatives to opiates for pain management. And I am the Medical Director of Emergency Department Pain Management here at St. Joe's. So part of what Mark was saying is we really find ourselves in trouble with opiates currently. And one of the goals for our ER, as well as for this program, was to talk about alternatives whenever possible. So we know the trouble with opiates. They have a high potential for addiction. There's often unwanted side effects. And for a lot of conditions that we treat in the emergency department, they're really not considered first-line therapy. In case you don't read the news or didn't know what's going on, we are in the middle of an unprecedented epidemic. The CDC is constantly putting out statistics and warnings about opioid use for acute pain as well as for chronic pain. And to give you some idea, the drug overdose deaths are about 50,000 a year, and prescription opioids are rising as the lead cause of drug overdose deaths. And this is the first time historically that we've seen this. It's typically illicit drugs bought off the street, but now it's trending towards prescription medications that are leading the deaths for young people. In 2013, some stats that are quite scary: about 20 women die every day from a prescription drug overdose. More women have died from drug overdoses than MVCs, and we're seeing almost 1 million women in the emergency departments for drug misuse and abuse. So this is a huge burden on our healthcare system, and we really need to start thinking about how we can fix it. So what your opioid prescribing measures as physicians is really what matters. This was very surprising to me in my research that Vicodin is the #1 dispensed prescription in the United States for the past 6 years. So with all the comorbidities and the rise in obesity and the other public health concerns that we're talking about, to see that Vicodin is really the medication that's mostly prescribed, I thought was very disheartening. It's followed by levothyroxine and lisinopril. 4 out of 5 new heroin users do report that they first dabbled with opiates through a prescription by their physician. And then 94% of heroin users in treatment said that they started using heroin only when they couldn't get prescription opioids or they became too expensive. So our goals are to really try to be proactive and not prescribe opiates, therefore decreasing the number of people on opiates, hopefully then not moving on to heroin. So if people are on opiates already, that's another issue. This Alternatives to Opiates program is to prevent people from getting started on opiates. One article that was published in The New Scientist compared the opiate overdose epidemic to HIV/AIDS, in that we have not seen so many young Americans, predominantly white Americans, die since the 1980s due to AIDS. So we are now looking at the future of our country, that they're just dying. They're dying in masses. Interestingly, there has been some physician discrimination against people of color, and therefore some protection against this epidemic for patients that are Hispanic or African American. So the physician discrimination leading to the decreased number of opiate prescriptions, because physicians are concerned about diverting or misuse, has actually protected this population. So we know that if we are diligent about opiate prescribing habits, we should see a change in the trend of overdose deaths. We see that Hispanic and African Americans do not have such high death numbers, overdose numbers, so let's try and swing the pendulum so that we're able to collectively stop this epidemic. If you look at our comparison internationally, we are prescribing a huge percentage of the world's opiates. So Europe's percentage, their portion of total population is about 11.4%, and they consume about 28% of the world's opiates. But in the United States, we actually only make up 5% of the world's population, but consume 56% of the world's opiates. So it's not a world problem, it's a United States problem. The international standard of care, when we look at that, people who, every man, woman, and child in the United States can have a bottle of opiates when we look back at 2013. So it's not just we're prescribing them for, serious painful issues. We're prescribing them so much so that every man, woman, and child can have their own bottle. When we look at Japan on average gives about 26 milligrams of morphine per person per year. The United States gives 663 milligrams of morphine when we talk about morphine equivalents. So if you go into the hospital, you have acute appendicitis, you're going to get morphine, and that's very appropriate. To say you'll get 26 milligrams of morphine in a year if you have a severe illness is reasonable, but to say that the United States is giving every man, woman, and child 663 milligrams of morphine a year is a little bit much. So I'm not saying let's not use opiates. I'm telling you that opiates play an important role in emergency department pain management. They are an amazing drug, and we need to continue to utilize them, but we have to be very judicious and responsible when we use them, and we have to seek out alternatives whenever possible. Our attempt to correct the opiate overdose crisis, they haven't been working. So let's try and look to innovative strategies and implement them at a national level. And I think that that is the way we are going to stop this crisis. So Dr. Rosenberg and I started collaborating on an alternative to opiates program, which we fondly call ALTO. And this protocol has been in the making for about 2 years. And we were able to go live with the protocol January 4th of this year. What it is a multimodal non-opiate approach to analgesia for specific conditions in the ER. One of the early investigators of this movement was Dr. Sergey Matov out of Maimonides. He has been on an individual level promoting alternatives to opiates, but unfortunately he does not have the departmental support and does not have a formal protocol in his emergency department, but he is one of the early investigators. The goal of the ALTO project was to utilize any approach possible to get good pain relief that is non-opioid, but to remember that opiates can be used as a second-line treatment. They can be used for rescue medication. Another focus of the ALTO program was to help educate patients about realistic pain management, that most pain will not be brought down to a zero without interventions like a nerve block, but that we want patients to have tolerable pain levels, and we also want to educate our patients about misuse of opiates and addiction potential. So this CERTA concept really just implies we are utilizing many medications, and they're working at channels, enzymes, and receptors. So instead of just agonizing the mu receptor for all painful conditions, let's agonize or antagonize a variety of receptors and enzymes to achieve pain relief. That means we're going to use quite a few different medications, not only a tablet of Percocet, but instead different medications, a variety of them, to work synergistically. So we're using COX inhibition, NMDA receptors, nitrous oxide. What that translates to clinically is the medications you see here. So not every one of these medications is used for every condition, but we try to identify what role this medication can play in treating your pain as to not prescribe opiates to the best of our ability. So how does this get applied in the ER? The ALTO appropriate conditions are listed here. These are conditions that have evidence, literature behind them as having alternative modalities that are successful for treating pain. So I'm going to go through each condition and share with you what we do here at St. Joseph's in managing these different conditions. And we're going to start off with renal colic. Renal colic is treated with Toradol, a liter of fluid, as well as Tylenol. And the star of the renal colic protocol is the cardiac lidocaine. So we're giving 1.5 milligram per kilogram. This is given in 100 mLs of normal saline on a pump over 10 minutes, and the max dose given is 200 milligrams. Where did we come up with lidocaine for pain? It started in 2004 with an article that talks about lidocaine use for intractable cancer pain in patients on hospice. The investigators were watching their cancer patients become very sedated and have undesirable side effects from the PCAs and the morphine drips that they were on. So these investigators had read a little bit about lidocaine as an analgesic and started to implement it along with opiates or in lieu of opiates. And this study found that patients on lidocaine had improved pain scores, fewer side effects. There was little to no toxicity reported, and patients reported improved quality of life when given lidocaine. Additional studies in Cochrane and other meta-analyses evaluated lidocaine for post-operative pain relief, and the lidocaine in this study reduced pain at rest with movement and with coughs, and there was no statistical difference when we compare lidocaine to opiates. The Cochrane review outlined some exciting bullet points, which are the lidocaine worked quickly and could last up to 24 hours. Patients required less opiates, less rescue medication. There was a decreased length of stay in the hospital, quicker bowel function return, and less nausea. There was no difference in the rate of death, arrhythmia, or toxicity. So the Cochrane statement here is there's moderate evidence that intravenous lidocaine does have an impact on pain scores when you compare it to placebo. The genesis for lidocaine for renal colic comes out of Iran, where there are no anti-inflammatories available intravenously. So in Iran, for renal colic, it's really morphine. And there were a lot of patients who could not tolerate morphine, or there was not a lot of pain relief when morphine was given. So these investigators used lidocaine. They started off with a case series. It built up from there, and they developed a study where they had a randomized control sample of 240 patients with renal colic. They compared the intravenous lidocaine 1.5 milligram per kilogram to weight-based morphine of 0.1 milligram per kilogram. And what they found was not only was lidocaine effective, it was actually superior to morphine when you look at 5, 10, and 15, and 30 minutes post-administration. There was no significant difference in the side effects when you compare it to morphine. For example, perioral numbness, transient dizziness, or dysarthria were a few we see in lidocaine. Traditional morphine side effects are listed here, but really when you look at patients without side effects, the numbers are not significant. Lidocaine, 87.5%, had no side effects compared to 86.7% with morphine. The hypothesis as to how this works and why it works so well is that lidocaine changes the sympathetic tone of the smooth muscle in the ureter. Therefore, it prevents that peristalsis, that squeezing, and therefore relaxes away the pain. This is found to be sustained and will offer complete relief, whereas morphine does not achieve that. The intravenous lidocaine really is a wonderful tool when treating renal colic and does not have many significant side effects or complications. So to recap, traditional anti-inflammatory with fluids, but the cardiac lidocaine has really changed our practice here, and we have quite a few success stories. Lumbar radiculopathy, I know we all see lots of lumbar radiculopathy, and it can be a very challenging disease. Neuropathic pain is terrible, and patients are really looking to you for some relief. The lumbar radiculopathy algorithm involves anti-inflammatory as well as Tylenol. There are studies that look at NSAID with Tylenol as helping to achieve superior analgesia as compared to single agent alone. So whenever you have an inflammatory condition, adding Tylenol to ibuprofen or to an NSAID can elevate your pain management, and patients will have improved relief. We do add Flexeril or Valium, depending on if the patient has received Flexeril or is already on it at home. We will go to Valium instead. And then also trigger point injection, which I will get into earlier, but you'll see trigger point injection as a modality in a few of the ALTO conditions, and it really works very well. Gabapentin is a medication you should not be afraid to start, and you should be looking to start in any patient with neuropathic pain. Lumbar radiculopathy in particular, but also your patients with diabetic neuropathy. This is a great medication. You can start with an analgesic loading dose in the emergency department. For patients who are under 70 kilograms, you can give about 300 milligrams. The anesthesiologists recommend going up to 600 milligrams as a loading dose in patients who are over 70 kilograms, and discharging patients with 300 milligrams at night is a good practice. Corticosteroids, there is some evidence for corticosteroids, but there has to be a risk-benefit discussion. And also lidoderm patches. So our pharmacy cannot keep up with the amount of lidoderm patches we're prescribing. We've seen very, very good results. They provide relatively quick, long-lasting relief for our patients, and you can put a maximum of 3 on. I think the idea of utilizing topicals is very important and is a mode of administration that we often don't remember to use. And patients who have lumbar radiculopathy may already be on opiates. And when those patients come in and they're on a lot of opiates and they're chronic opiate users, they have different brain chemistry. So we have to remember that adding opiates to an already opiate-tolerant brain does not always achieve the analgesia that we want and can actually cause progression of hyperalgesia and allodynia. So to utilize a different receptor like the NMDA receptor and to antagonize it with something like ketamine will really help get that patient's acute flare under control. So using an infusion or bolus dose of 0.3 followed by a drip at 0.1 milligram per kilogram per hour will help to get that patient's pain tolerable. Then you can stop the drip and you can discharge them home. Moving on to headache and migraine. So there's a lot of evidence that headache plus opiates is just bad. We have numerous studies that compare opiates to other medications for headache relief, and they are not efficacious. Opiates can actually make traditional migraine medication less efficacious. They promote chronic migraine pain, migraine relapse, and patients on opiates for headache pain tend to have increased ED visits. Patients who are opiate dependent with migraine also have more disability, depression, and anxiety. And really the only recommendation for opiates and headache is for pregnant women with intractable migraines who don't have other medications that they can use. So really we should never be giving opiates for headache pain, and we do have to look for alternatives. So luckily the Cleveland Clinic felt the same way, and they evaluated their opiate use, and they found that in their emergency department, opiates were being prescribed in the ED 66% of the time, and patients were given opiate scripts for home 44% of the time. So they developed an algorithm along with neurology, and after implementation of this, they dropped their prescribing in the ER to 19% and discharged scripts only 5%, and this was significant. So this is an adaptation of their algorithm. They start off with relatively traditional headache medications, Toradol, Reglan, and sumatriptan. Sumatriptan is classically given immediately during the onset of headache. However, we found that it can be given up to 24 hours and still be efficacious. So I advocate for the use of sumatriptan in patients who have headaches, specifically migraines, and even if they had taken a dose of sumatriptan before they came in, you can redose it in the emergency department. If they have more than 50% relief, these patients can be safely discharged. However, if they do not have tolerable pain and you want to move on, the recommendation is dexamethasone. Based on weight and comorbidities, the dose can range from 4 to 8 milligrams, given intravenously. This is best if used for patients who have headaches that have been going on longer than 24 hours or have a history of relapse. This breaks the pain cycle and decreases the rate of readmission to the emergency department. Magnesium 1 milligram IV should be added, and valproic acid 500 milligrams intravenously is an additional medication that should be utilized. If patients do have relief here at this point, then they can be safely discharged. However, if patients are still having migraine pain, then the recommendation is Haldol. It is a successful antiemetic, and it also helps with migraine pain. After all of these medications are given, at this point, if the patient is still in pain, then we really need to think what else is going on. This is not a time to lean on opiates. Opiates are not a diagnostic tool. If you give the opiate and the patient feels better, did we really get to the root of their problem? So in the Cleveland Clinic algorithm advocates for further evaluation in an observation setting with a neurology consult if a patient truly does not have relief after going through this algorithm. Yes, are there more admissions to the observation unit? Are there more neurology consults? Sure. But starting the opiates from the ED and having that continued on the outpatient basis has a much worse side effects than just utilizing your observation unit. Some additional things to consider: if there is a lot of muscle spasm or there seems to be a tension component to the headache, adding muscle relaxant in lieu of some of the other medications or adding it in addition is a good practice. Trigger point injection and lidoderm patches. Cleveland Clinic did not put Tylenol on their algorithm, but if there's an issue with giving some of the other medications, Tylenol certainly should be added. Again, the evidence reveals that if there's any kind of muscle spasm or inflammation, adding the Tylenol can provide better analgesia with an NSAID. And remember, there's really no role for opiates. Corticosteroids have really a risk-benefit place in this algorithm. There are a handful of studies showing benefit, but with patient comorbidities, we have to be careful. Valproic acid, looking at the Cochrane literature, There is an NNT 3 and 7, depending on the study that you look at. Valproic acid is actually superior to sumatriptan when it's looked at head-to-head. So although sumatriptan may be a medication we're more comfortable with when talking about headache treatment, valproic acid is a medication we should start investigating and becoming more comfortable with because it's quite efficacious and it's a nice medication to utilize on an algorithm. Musculoskeletal pain. So for acute neck, upper, and lower back pain, or any joint or soft tissue pain, we want to make sure that we're turning to non-opiate modalities first. The back and neck pain approach includes NSAIDs, Tylenol, again, if there's a tension component or muscle spasm, adding Flexeril or Valium, utilizing topicals like Lidoderm patch, and then trigger point injection. A lot of these patients will not require an IV and may not want to have intramuscular medication. So remembering that there are intranasal medications that can be given is important. Intranasal ketamine, giving at a 0.5 milligram per kilogram dose, can be efficacious and can help break that pain cycle. So don't think that you have to put in IVs everybody to give ketamine. It's a very good medication and it can be given safely intranasally. For joint pain, similar algorithm, but we really need to start leaning on some of our procedural skills for biceps tendonitis or for different bursitis pain that patients have. We need to remember that just a little bit of local anesthetic, possibly with some corticosteroids, can offer significant relief. To flood the body with opiates to get for such localized pain, I think is overkill. I think we need to appreciate that the focal treatment of whatever the painful condition is will really benefit the patient in terms of their functionality compared to just giving a sedating medication with a lot of side effects. So revisit injections, revisit procedures, and remember that they can really be helpful and they can achieve significantly improved pain as compared to giving opiates. And the last thing we're going to talk about for conditions is extremity fracture and joint dislocation. So this is a big, this takes a lot to get a whole department on board for ultrasound-guided nerve blocks. And the ultrasound-guided nerve blocks are really the crux of treating dislocation and fracture pain using alternatives to opiates. Ideally, in our emergency department, we use nitrous oxide when the patient arrives. We can wheel our mobile nitrous oxide unit to bedside. We can let the patient hold the mask on their face. We can titrate the nitrous oxide up, and we can relieve their anxiety and relieve their pain. We can also utilize intranasal ketamine. And why are we doing all this? We're doing this to get quick, significant pain relief while we set up for everything else we're doing. We know that setting up for an IV can take a few minutes, especially if the nurse is with a sick patient, or we had another thing we're dealing with across the department. So by using inhaled gas as well as intranasal medication, we're giving patients immediate pain relief, and it buys us some time to gather our resources. Once the patient has these medications on board, you would ultimately like to do an ultrasound-guided nerve block. If there's a dislocation, you can use lidocaine 0.5%, and you're going to do a perineural infiltration, depending on whether or not it's the brachial plexus or the femoral nerve. You want to bathe whatever nerve is involved in pain, and you can achieve complete, almost surgical anesthesia with this nerve block. It will allow for very easy relocation of the joint, or it will provide significant, if not complete, pain relief from the fracture. So we had an 83-year-old woman who came in with a terrible hip fracture. She received a total of 20 milligrams of morphine. She was still screaming. The physician taking care of her saw that I had just come in for a shift. He said, you know, I know that you're doing the nerve blocks. What do you think about this patient? So we talked. I talked to the family. I explained what I wanted to do, and we gave her a nerve block. And within 60 seconds of me finishing the block, she was crying. We were hugging, and she said her pain was, for the first time, tolerable. And it was really a beautiful moment for everybody because it's so powerful, the ability to take away pain like that. And although it's hard to get everybody trained and on board, I think it's important to move the departments towards this goal of having a few docs at least in your department who can perform these procedures because they can really be life-changing. They can change the patient's hospital course, and they're really a wonderful tool. The discharge medication for extremity fracture is a little controversial. A lot of countries around the world do not give opiates for extremity fracture. A lot of these patients are not ambulating, they're using crutches, and what the international community is advocating for is around-the-clock combination treatment with Tylenol and an NSAID, as well as remembering to elevate, remain immobile as best as you can, and to rest and use ice. The physicians in Holland looked at their opiate prescribing habits and our opiate prescribing habits, and we found that they're drastically different. They're significantly different. So operatively treated ankle fractures, inpatient patients get 98% of Americans who are in the hospital for operative ankle repair get opiates, but only 64% of patients in Holland get opiates. And then only 6% of patients in Holland get opiates when they go home, whereas 82% get opiates in the States. And when you read the article, their pain scores are low, their patient satisfaction is not suffering. So we have to appreciate that opiates do provide fantastic analgesia, but we're in the middle of a crisis. So to utilize alternatives and to at least try non-opiate medications first, I think you'll be surprised that patients do quite well. I think we underestimate our patients sometimes because we just know that the opiates are given, and so we give them and we'll say that's fine. But sometimes the patients go to their physicians, and if the opiates are working well, then the physician says, well, let's go ahead and continue with that then. And before you know it, the patient's on opiates for 6 months or a year, and it increases their potential for addiction. If they're put on anti-inflammatories and Tylenol and they're elevating and they're icing, they may not need the opiates. So to decrease the risk that they may not need them, it's important to remember there are alternatives. Some modalities, and also to talk about nitrous. So ultrasound-guided nerve blocks, as I mentioned earlier, is really focused, non-sedating pain control. It can be long-acting, it can be short-acting, depending on the medication you give. You can do proximal blocks, like brachial plexus blocks, or you can do distal single nerve blocks, like an ulnar nerve block. And that provides fantastic analgesia for complicated lacerations or maybe to reduce a Colles fracture. And just looking at YouTube, you'll find a lot of sponsored videos as well as just physicians doing videos and really taking a little bit of time to investigate this. You'll find that it's not all that difficult and it's something we can certainly do, and it's well within our capability of doing. Trigger point injections. I was first introduced to trigger point injections while I was doing my neurology and my PM&R rotation through fellowship, and I was amazed that we weren't doing more of them in the ER. We're doing central lines, we're doing joint aspirations, and these are so much easier and so much more simplistic. I think that they really have a role for musculoskeletal pain in the emergency department. What a trigger point is a focal area of spasm and inflammation. You typically see it in the back, in the trap, the rhomboid, or the muscles of the low back. It can be associated with some chronic myofascial pain syndrome, or it can just be that the patient pulled out their back a couple days ago and they just cannot find relief. The way that you identify a trigger point is just palpating the area of tenderness and kind of mapping that tenderness to identify if there is a pain generator within the global area of pain. It may be felt like a nodule or a taut band of spasm, and when you push on it, the patient really will have reproducible pain. The way that you perform a trigger point injection is twofold. There's a component of dry needling, and also you give some local anesthetic. The dry needling basically causes a disruption of that spastic feedback loop. It interrupts the abnormal activity within the muscle fibers, and sometimes the patient will feel a jerk or a spasm, and that's an indication that the muscle is finally relaxing. After the jerk or the spasm, the patient will often report they have significant relief. The local anesthetic, just 1 or 2 cc's that you infiltrate into the area afterwards, serves 2 purposes. It will dilute some of the substances that have been released from the dry needling, and it will also give a little bit of relief if the patient had any soreness from the dry needling procedure. Indications for trigger point injection include a palpable trigger point, that the trigger point reproduces the pain, and that the pain has been there for a little while. So this is not MVC whiplash pain that the patient's had for 6 hours. This should be pain that's been brewing for at least 24 hours that has led to the development of a distinct spasm. So it obviously does not work well if the whole muscle is in spasm, but if there's a specific area, it can work really nicely. You don't want to perform this procedure if there's cellulitis over the area, if the patient is anticoagulated and you're concerned about compressing the site. Of course, if there's an allergy, you will not do it. It's best for myofascial pain as outlined in a systematic review in 2013. This looked at patients who had dry needling versus placebo for trigger points, and the dry needling was much more efficacious. Patients had pain relief out to 4 weeks, and they felt that patients who had injection of local anesthetic in addition to their dry needling had improved pain scores than just dry needling alone. All you need is a little bit of Marcaine, or you can use lidocaine, but the Marcaine will last longer. There are some physicians who use steroid in their trigger point injection to longer lasting anti-inflammatory effects. 25 gauge needles, which you're looking to use, very small. You'll clean the area with alcohol. You put a Band-Aid on after your procedure, and you always want to do it with the patient's consent. So basically what I just spoke about, identify the taut band. You want to pinch the area in between your finger to elevate that trigger point so it's in between both fingers, and you want to insert the needle moving in and out in a circular motion. You may feel a jerk or a twitch, and that means the trigger point is relaxing. And you can see here, you elevate the trigger point, you put the needle in, and you just go in and out in a 360-degree motion and break up that trigger point, and then just infiltrate some local anesthetic at the end. There are YouTube videos on this. So check out YouTube. Lastly, nitrous oxide. So this is my training session for the residents where one of our colleagues offered to be our patient for the day. Nitrous oxide is a tasteless, colorless gas, and it's administered in combination with oxygen. You can give it via a full face mask or with a nasal hood, and the maximum concentration of nitrous oxide that you'll administer is 70%, always allowing for 30% oxygen. It's absorbed via pulmonary vasculature. It does not combine with hemoglobin or other body tissues. Therefore, it will be working within 60 seconds, and then it's out of your body in 60 seconds. It's a nice analgesic, but also a strong anxiolytic. So there's a lot of research that looks at anxiety contributing to pain, and if we can relieve our patients' anxiety, they tend to do better, and they have better pain relief. So the benefits of nitrous oxide are not only the analgesic, but also the anxiolytic component. There's really no monitoring that you have to do for nitrous oxide. Most of the dentists and oromaxillofacial surgeons use nitrous oxide up to 70% in their outpatient offices without any monitoring. It's really not necessary, but since we are in a clinical environment, we are in the emergency department, the pulse oximetry never hurts. So we do ask that our clinicians put the pulse ox on. There are no NPO requirements. The patients can drive after administration, and there's really no IV necessary. The medication is quick on, quick off. The evidence is astounding. There's fantastic evidence for pediatrics. You can use it as a single agent for pain, or you can use it in combination with other agents for sedation, especially when attempting to get a line on patients or repairing lacerations. There's a lot of evidence in pediatrics. And there's some mounting evidence for acute pain management in adults. So we're hearing more frequently about the appropriate use of nitrous oxide for adult population, whether or not that's pre-hospital pain relief or for active labor pain, and it's even being used for colonoscopy and bronchoscopy. So although we think of it as laughing gas and we think of the dentists as the people who use it, it actually has a wonderful role in emergency medicine, and I'm hoping that it gains more popularity and that we're able to use it for a variety of conditions. For us, the indications for nitrous oxide use in our department are lax, INDs, any wound care, foreign body removal. I've used it recently to put a central line in a very awake patient who was very nervous about having the central line placed, but had some borderline vital signs and some comorbidities. I didn't feel comfortable giving him opiates. He wasn't having pain. I didn't feel comfortable giving him benzodiazepines with his blood pressure and the comorbidities. So the nitrous oxide was a fantastic medication. He held the mask on himself, and after the procedure, he said he felt like he was just kind of resting. He didn't have any complaints. He felt well, and it allows the provider to provide better management for your patient when you know your patient is not so nervous. Contraindications for nitrous oxide use are patients who have severe active asthma or severe active COPD. Putting that full face mask on can be a little bit jarring for patients, especially if there's air hunger. So we do not recommend using this in patients who are having any respiratory issue. There's also the nitrous oxide inhibits vitamin B12 synthesis. So any congenital issue where a patient has B12 deficiency or pernicious anemia, you would not want to utilize nitrous oxide. Any closed space infection or any trapped gas, like otitis media, sinusitis, or bowel obstruction, is a contraindication. When nitrous oxide gets absorbed into the bloodstream, it can cause gases to expand. And if any gases are trapped, it may lead to perforation or rupture. Patients who have psychiatric disease, have alcohol on board, or head injury, we don't recommend using it because it may make the patient a touch bit sedated and you may not be able to perform a good neuro exam. So if there's any concern about their mental status, we do not recommend nitrous oxide. And complex advanced cardiovascular disease, patients who have very poor ejection fraction, patients where you're concerned about active MI or other cardiac disease, I don't recommend using it. And first trimester pregnancy is a contraindication. It can contribute to teratogenesis. So a good scavenging system on your device is important to safeguard providers. And then, of course, you do not want to expose your patient. So doing a pregnancy test beforehand is important. So I just talked a lot, and I know that there may be some questions. I just want to follow up with the statement that you see here. If you've gone through using alternatives and you feel that the patient does not have adequate pain relief, then by all means, move along to opioids. And for appendicitis or for severe trauma, you use opiates. But for these, conditions, headache, low back pain, there really are good alternatives, evidence-based alternatives. So I think utilizing them will allow you to have a good discussion with your patient about alternatives and a good discussion with your patient about trying to avoid opiates. You have to also remember, if you are going to give opiates, that you sit down and you talk to the patients about potential risks and side effects. Sometimes patients are not aware that dependency can go along with opiate use. They may not think that their craving is an early sign of addiction. So education is a really important thing, especially if you're going to be sending them home with opiates, and you want to make sure that they have follow-up, that they're not just going out into the world with an opiate prescription, but that we can make sure that they're doing well and that they don't need any other follow-ups. So summary, this is the algorithm we use here at St. Joe's. I will also add on that the program not only includes the protocols here in the emergency department, but it also includes collaboration with our Department of Family Medicine, physical therapy, PM&R, and pain management, as these departments have adopted the ALTO philosophy of using opioids as a second line, if at all, for the painful conditions that we talked about. The ALTO program also works with a few detox centers and mental illness centers in the Patterson area, and we work with the St. Joseph's Healthcare Prescription Opiate Overdose Prevention and the naloxone distribution program, so that our nursing staff involved in this program can educate patients, family, and friends. For people who are at high risk or involved in opiate use, provides them information about opiate addiction, some of the red flags that addiction is escalating, and also puts a naloxone kit either in the home or on the person of somebody who may be near an opiate addict, so that they may be able to administer naloxone before the first responders get there. So that's just an overview and some more information about the program, and I'll turn it over to Dr. Rosenberg.
Thanks, Alexis. When we first talked to the press about this program, all they heard is, we don't give opioids, we give Tylenol. So as you see, it's a lot more than that. Alexis, I do have a couple questions before we open it up. There's a lot of confusion with the terms, and what is narcotic, opioids? What's the difference?
So opiates are substances that have the same chemical makeup as opium. So for example, heroin and morphine are opiates. Opioids are synthetic medications that bind to the opioid receptor. That includes hydromorphone, fentanyl, methadone. So they can be used interchangeably, but really opioid is the broad term that we probably should use more often. Opiate implies something similar to opium. Narcotic is a word I think that we need to move away from as clinicians. We are physicians and we do not prescribe narcotics. If we did, we would be giving crack and heroin. In fact, we prescribe opioids. Narcotics are illicit substances that are bought and sold on the street. So when we talk to our patients and we talk to our administrators about this crisis, we need to be using the right words. And narcotics,
I don't know, but I like it a lot.
clinicians prescribe.
Great, thanks, Alexis. I have most of you off mute. There's a few who there was a lot of background noise, so I'm keeping you on mute. But if there's any questions, I think it's open mic, so we could hear you just fine. It would actually be very funny if we're disconnected and there's nobody online, but Lauren, are you there?
I'm still here.
Okay, all right. You were my test. Any questions from anybody? Brian, go ahead. You're open. You can talk. All right, so I have some questions here. Are we giving Tylenol IV or PO, Alexis?
We are currently giving Tylenol PO. I did petition our Pharmaceutical and Therapeutics Committee for IV Tylenol, and despite the evidence that I presented and the importance that IV Tylenol has for pain relief when we're talking about alternatives to opioids, I got shut down. So they were impressed with the discussion and with the evidence, but felt that the cost is really prohibitive. So at this point, we are using PO. If you do look at the literature, the IV Tylenol is not more efficacious. It just works much quicker. So patients will ultimately have the same pain relief, PO, IV, and rectally. It's just the IV tends to have a peak pain relief at 15 minutes, whereas sometimes PO we're waiting up to 60 minutes. So they felt with the cost and with just the time as the factor, they did not approve the Tylenol. But I think I would like to revisit that next year, especially with the success of our program.
Another question is, do you have any concerns with ALTO IV and black box warnings? I'll address that from a palliative point of view. Had great success using Haldol IV for nausea and vomiting. Also Haldol sub-Q. IM has erratic absorption, so I prefer that it's given IV or sub-Q. From a pain point of view, Alexis, any concerns?
I do recommend that if you don't have an EKG, you can get an EKG and verify that there's no concern for QT prolongation. Also, I am an advocate of putting the patient on the monitor when you're going to be giving Haldol IV. We have not had any issues in our emergency department. I think we just have to be aware of the risks and be judicious when we give it. And I think that just includes EKG and cardiac monitoring.
Another question, same type of question. Do patients receiving IV lidocaine need to be on a cardiac monitor?
Yes. When patients receive any kind of lidocaine outside of subcutaneous infiltration for a lac repair, they should be on a monitor. So anesthesiology, when they administer ultrasound-guided nerve block, the patient must be on a cardiac monitor, and the same goes for intravenous lidocaine. The dose that we're giving of 1.5 milligram per kilogram has very, very rare association with cardiovascular toxicity, but you always have to appreciate the strength and the side effects of your medication. So again, ultrasound-guided nerve blocks with ropivacaine or lidocaine, as well as intravenous lidocaine, requires cardiac monitoring. And I will also say, if you are going to be doing nerve blocks or using intravenous lidocaine, you need to make sure that you have intralipid available in your emergency department, which is the emergency resuscitation medication. It can't be something that you have to wait to get from pharmacy. It really should be in your department.
All right, next question. There's a couple regarding ketamine, and I think it probably deserves a little bit more of a whole discussion, but do you pre-treat your patients with who are receiving ketamine? There's one question about antiemetics. There's another one about giving them benzos. So do you give any medication when you're given intranasal ketamine?
Intranasal ketamine needs absolutely no pre-medication. The absorption from the sinus mucosa, it's a very little bit of ketamine that's getting through. And although it is a quick absorption, the dose that we're giving should not cause any dissociative side effects or any of the nausea or vomiting that you may see when you're using it for procedural sedation. The same goes for the dose intravenously. The intravenous dose of 0.3 milligrams per kilogram and the 0.5 milligram per kilogram for intranasal are, again, subdissociative analgesic dosing. So as we look at the ketamine curve, the subdissociative ketamine is all the way at the bottom at the doses that I'm advocating here. One notch up the curve will be recreational use. So if you do toe into recreational use, the patient may describe a little bit of euphoria or may kind of feel a little bit of an altered sensorium, but not until you go all the way up the ketamine curve to the dissociation section, if you will you have those vital sign abnormalities, nausea, vomiting, or emergence. So what we're looking at these doses are very, very few side effects, maybe just a little bit of euphoria, but really no pre-treatment necessary. If you do toe into that recreational area and the patient's having kind of a dysphoric sensation, I will say that it certainly is not a bad idea to give a touch of a benzodiazepine. We have not had any issues with nausea or vomiting with these doses here in our ER.
Thanks, Alexis. You know, we even have a couple physicians who treat fracture pain with intranasal ketamine in triage, so getting immediate results without any complications. Another one from Michael, I would love to have a copy of these protocols. Alexis, you were talking about the pamphlet that you put together of the program. Maybe we can get that to Lauren and get that out to anybody from New Jersey ASEP who's interested in it.
Sure.
I think that would be great. You know, one of my goals, what I'd love to see here is there's so much interest in this protocol. And I think New Jersey is such a progressive state when it comes to emergency medicine that maybe with a little bit of work, we can really lead when it comes to non-opioid pain management and get on board with the ALTO program. Another question, how do we get permission to use ketamine in the emergency department? You know, the way it's set up at St. Joe's is all of our conscious sedation, moderate sedation, mild sedation has to go through anesthesia, and we have a wonderful working relationship with anesthesia. And we do all the intubations in the emergency department, as many of you do, and we've had no problems with airway management either. So when it came time to, you know, we use propofol, we use ketamine, so we have no problem getting that approved. And I think if some of your anesthesiologists or whoever is pushing back about ketamine use, I think maybe myself or Alexis can be there to help share articles and experience so that it becomes less voodoo and just good medicine. So Alexis, any comments?
No, I think that any colleague, any physician colleague that looked at the evidence for ketamine for intubation or for pain would really, I think, have a difficult time saying no. I think when you put the pile of literature in front of them, it's certainly within our practice to use. We use much more dangerous medications than ketamine every single day, and it can provide such nice pain relief. It can provide optimal intubating conditions, and it's a nice medication to be able to use, and I think all ER physicians should use it. So I would be happy, as I know Dr. Rosenberg said, he will also be happy to work with any of you who feel that you need a little bit more help to convince administration.
Next question is very similar, Alexis. It's on nitrous oxide administration. And let me address it again, similar to the ketamine. But this was much harder. When we went to get approval to use nitrous oxide, anesthesia was a little pushed back because they don't even use it anymore. And we're very fortunate here that we have a very active dental and maxillofacial program that uses a lot of nitrous oxide. And that's who we were able to go through to strong arm any resistors about use of nitrous oxide. To my absolute amazement, when we went to get privileges to use it, there was nobody even trying to stop us. Everybody was fine with it. Nitrous is so safe to use, and it's really considered an analgesic, and it was very, very simple to get approval. The big concern was safety. Are people going to abuse it? And we can share with you the device that we have. It's very difficult to abuse. We have it stored, and we have a camera that's right on there, so anybody who's taken the machine, we know who it is. It is in small tanks. It's controlled by respiratory therapy, and we can go over all those protocols with you. But I'll tell you, we had a patient come in the other day with a shoulder dislocation that was very difficult in the past to put into place. But between a nerve block and some nitrous and some ketamine, he was zoned out enough that we were able to manipulate this back into place without any difficulty. And moments later, he was awake and feeling comfortable. Just an amazing drug, an amazing adjunct to this program. Alexis, any comments?
No, I think that, again, there's a lot of literature that administrators or even ER doctors are not aware of. And when you for nitrous oxide, it's very, very safe. It's used in pediatrics nationally. There are lots and lots of studies, and there's lots of talk about the safety profile. And you just look at thousands and thousands of cases of successful use with very little downside. And again, if we look at opioid alternatives, nitrous oxide is one of the safer medications that we use. And I just think it takes a little convincing because it's classically an outdated or anesthesiology but really emergency medicine is where it belongs, and it's a fantastic medication and has really broad application.
There are 1, 2, 3, 4, 5, 6 comments about excellent program and thank you, and similar types of comments. So on behalf of Alexis and I, there's nothing better than having a colleague give you those types of comments. So very much appreciated. That exhausts, oh no, there's a lot more questions all of a sudden. Wow. We have concerns from nurses, the ketamines and level of monitoring required, even though giving analgesia doses and not sedation doses. I think this is all education. Yes, the nurses do have some concerns. What is their responsibility to monitor? We can share our protocols, what our nurses do as well, if that's helpful. Are you working on protocols for surgical and surgical abdominal pain? Alexis, I'll leave that to you.
At this point, I'm not. We have so much to do with this program and this program's success and the publicity. So I am focusing mostly on the conditions we talked about. But I will say that some of the colleagues in this field, some of my colleagues in New York and also in Canada, are finding more and more uses for ketamine every day. They're getting nice pain relief, even with surgical abdominal pain. So although that's not a focus of mine right now, it may be in the future. And I will say one of the medications is probably going to be ketamine.
Next question, right up your alley. Talk about diabetic neuropathy and how can we treat those symptoms?
Diabetic neuropathy is a very, very hard condition to treat, and patients have excruciating pain. What I will say is, if the patient is not already on gabapentin or Lyrica, they need to be started on it in the emergency department. I used to think in residency it wasn't really our job to do that, but after pain management training and talking with the neurologist and physical therapy and family medicine, sometimes these patients miss appointments, they can't get to appointments, so they may not have good follow-up. So unfortunately, we wear a couple different hats in the emergency room, and we all know family medicine or primary care is one of them. So I do think it's our job to familiarize ourselves with these medications and to use them. If the patient is on gabapentin and they're taking 300 milligrams a day, that is entirely too little. The Cochrane studies look at using up to 2,400 milligrams a day before you really get relief of neuropathic pain. So if a patient is on gabapentin and they're under 2,400 milligrams, you can load them with 300 or 600 in the ER for their acute flare, and then you want to talk with them about potentially titrating up. Then it would be my recommendation to really work hard with your outpatient colleagues to make sure that patient has follow-up. The side effects, the most common side effects of gabapentin is sedation or dizziness. So when patients start taking it, they should start taking it at night. And then they can titrate up from there if they can tolerate the side effects. So when they come into the ER, work with them on what they're on at home. Don't be afraid to give an extra 300 or 600 as long as they're not at the ceiling around 2,400, and educate them that this is the ideal medication. I also will add Tylenol, and sometimes I do add lidoderm patches. I know that there's not much evidence for it, but again, when patients look down at their leg with neuropathic pain and they see a patch on it, I do think that there's maybe some benefit to the lidoderm, but I also think that there's a strong placebo effect, and there's a lot of comorbidities that diabetics have, and giving them opiates really can start them down a vicious spiral of decompensation. So I think exploring modalities and trying medications that we know don't have significant side effects is a nice way to approach it, but gabapentin is going to be the best medication you have for that.
Here's a great question, and it can't be answered very easily, but here it is. Take this. What do you suggest as a starting point in order to implement an ALTO program in the hospital?
Okay. You need support from your chairman. That is step number one. In order to get anything done in the administrative web of a hospital, you have to have a strong, well-respected advocate in your corner. That being your chairman or your medical director. They need to believe in what you're doing because they probably are going to be the ones to sell it to administration. I work with Dr. Rosenberg frequently as we built this protocol, but he was really the one to go to these administrative meetings, and he was the one to pitch what was going on. I think that without the support of your department or your ED administration, you're just going to run into a lot of red tape. So step one is to have the idea, gather your evidence, pitch it to your administration, convince your chairman, and then let your chairman do some of the political administrative hard work that sometimes we're not capable of doing ourselves as clinicians. But that's number one. I think if the chairman's on board and the chairman can push it, then things tend to fall in line. But I'll let Dr. Rosenberg comment further.
I think as an ASAP and a New Jersey advocate, I really think that just hearing these questions is putting a smile on my face. There's nothing more important in my mind right now for emergency medicine to wear a white hat and to deal with the opioid crisis and epidemic from the emergency department point of view first, I think is really something that will get everybody's attention. So Lauren will send out all this information Alexis and I are talking about, including my contact number and Alexis's contact number, and let us work one-on-one with you to help develop this program in your hospital. I think every hospital is going to be uniquely different, but even if we don't get the program started, parts of this we can initiate. There is another question talking about how much of a decrease in opioid usage did we see in our emergency department. And the data is very fresh and not completely looked at yet, but in our first 60 days of operation, we had more than 300 patients that were part of the ALTO program. All of those would have received opioids in our prior treatment protocols or pathways. Out of that, 75% of them were treated with alternatives to opioids rather than opioids. And let's see, I think there's one more question. Any protocol for gastroparesis? We have to laugh at that one. Go ahead.
So the one request I got from my very, very supportive Chief Medical Information Officer, who is our former chief of the adult department, was, Alexis, can you please help me manage gastroparesis? So I will share with you some anecdotal information from some of the other pain management colleagues in emergency medicine and what they're doing. There's not a lot of data on gastroparesis, and it's on my whiteboard as something to investigate further once everything calms down a little bit, and to try to have ALTO adopt gastroparesis. Right now, when I speak to pain management colleagues internationally, they are doing Haldol and Benadryl. Now, that sounds kind of like a situation that you're putting down a combative, aggressive patient, but the Benadryl has a strong antiemetic. We know it can be used as a strong antiemetic, and we know that it has some effect in decreasing acid production in the stomach. Not as much as Pepcid, but a little bit. Haldol, also a very strong antiemetic. We also know it has some sedation. So the protocols that I've seen have included really like 2.5 milligrams of IV Haldol and 25 milligrams of IV Benadryl. The patients tend to get pretty sedated. You have time to do any diagnostic testing that you'd like to do. They tend to be less sedated about an hour or two later, and the reports are that they have improved pain. I don't have any randomized control studies on it. I will just let you know that those are the grumblings I hear in the field, and I hope to, as a courtesy for my CMIO, investigate it further and maybe be able to get back to you, because I know it's a difficult condition to treat, and they tend to be difficult patients.
There's no more written questions. Are there any last questions from anybody? Well, a lot of work to do. I don't see any more questions coming up. I don't hear any more questions. I want to thank everybody for being on the call. This was short notice, and hopefully you found it to be helpful in all of our effort to decrease opioid use, abuse, addiction, and dependency. Thank you all.
Thank you.
That ends the call, everybody. I'm going to disconnect unless there's last questions. Thank you.